Assalamualaikum and greetings I bid to Sir Amizan and fellow friends. I am Nur Atira binti Nur Fuadi and along with my friend Chan Xinjing, we will present to all of you about hearing screening and update of pure tone audiometry test. Before moving on, let's take a quick view on what is pure tone audiometry. Pure tone audiometry is the main hearing test used to identify hearing threshold levels of an individual so that in case of hearing loss, we can determine the diagnosis of the degree, type, and configuration of a hearing loss. This provides a basis for diagnosis and management. On the other hand, screening, compared to a full diagnosis, is a much simpler method as it only identifies who may have a disorder and who is in need of a further assessment. Thus, routine hearing screening is slightly different from what we use in clinics, as we usually perform hearing screening programs in normal populations, most often in newborn screening programs, in rural areas, in school settings, or in high-risk areas such as for people who are working in factories or airports. Basically, we use conventional portable audiometers for screening, but there are also other modifications such as bootless or automated audiometers, which will be shown in the next few slides. Characteristics of pure tone audiometry screening. As the name suggests, pure tone audiometry screening uses pure tone audiometer, from the simplest one to the most complex one, as long as it can test at selected frequencies and intensities. It is a subjective test, which means that the subject has to show their responses either by using toys like in play audiometry, by raising their hands, or by pressing a button. Pure tone audiometry screening also only tests the air conduction method. The bone conduction method is not performed until a proper diagnosis is needed. Only few frequencies of the speech spectrum are tested and the intensities are given according to the age. For elder patients, it is common to have a bit of hearing loss, a condition known as presbycusis. So those who fail at 25 decibel need to be told that they might encounter a big problem to hear clearly. Refer those who fail at 35 decibel, screen at any frequency except at 4000 Hz. Screening needs to be done in a quiet environment with acceptable level of ambient noise. My friend will further explain after this regarding ambient noise level check, but basically ambient noise is the background noise in a scene or location. For that, we usually find a place that is naturally quiet such as libraries or management office. However, with recent modifications and inventions, there is also mobile audiology clinic with proper soundproof room and also Codewave audiometer which offers a bootless option. What makes this possible? Well, Codewave audiometer has physical passive noise blocking and active noise monitoring technology that provides the core bootless testing ability of every Codewave audiometer. Next, subject must not be given any cues. Tester should be aware so that there is no rhythmic presentations. Also, positioning is important so that the subject couldn't see any movement during stimulus presentation. Make sure to position the subject where they can't see you, but we can see their response. In pure tone audiometry screening, examiners do not conduct formal threshold determination procedures. Instead, we screen at only selected intensities, which marks the ability to hear within normal limits. At least two positive responses are needed at each frequency to pass. In case of no response at normal intensities, minimal response level for a stimulus should be obtained. Only by then, the results are recorded as either a pass or refer. So, how is screening done using pure tone audiometer? Basically, What I'm sharing here is a hearing screening guideline in a school setting, which involves both the young and older children. Firstly, start from the right or better ear first. If the child reports greater hearing problem in the right ear, begin with the left ear. Next, preset 1000 Hz at 40 dB for conditioning. This is to make sure that the child understands that they need to search for the sound stimulus. This may be easier as 40 dB is a supra-threshold level for people with normal hearing. Observe for their response before proceeding to 20 dB. Tune is presented 3 times and the child must respond to at least 2 presentations. There is also another method in which there is no need for conditioning, so straight to testing at 20 dB. If there is no response at 20 dB, increase the intensity by 10 dB steps until a response is observed. If a response is observed at 30 dB, return to the screening level and provide another opportunity at 20 dB. If the child does not respond, the lowest response level is recorded. Then, move on to adjacent frequency switch of 2000 and 4000 Hz, following the same procedure for 1000 Hz. Results are then recorded. As for adults, there is no need for conditioning, so proceed with 20 dB for 1000 Hz, 2000 Hz, 4000 Hz, and an additional low frequency of 500 Hz. The other ear is tested using the same method. Lastly, only then the result is interpreted as either a pass or referred. As otitis media is common in children, any child who does not pass the pure tone screen is seen during the same session for otoscopy and tympanometry. Children who have normal tympanograms but do not pass the initial hearing screening are suggested to be tested again at another station. There are a few variations of pure tone audiometry, and what we commonly use for screening is play audiometry and pure tone audiometry. Play audiometry is used for children who are 2.5 years old and above until preschool. This method teaches a child to associate a response with a play task, usually by using blocks, figurines, or anything that gains a child's interest. Because we typically perform hearing screening in a school setting which involves younger children, it is often preferable to conduct screening using play audiometry suitable with the age. There is also another test that also uses audiometer, which are behavioral observation audiometry (BOA) and visual reinforcement audiometry (VRA). However, these tests are unlikely to be used in screening outside a clinical setting, mainly because they need to be performed in a controlled setting and require bulky equipment such as speakers and visual reinforcers. As for older children and adults, pure tone audiometry is easily conducted during screening. It only requires the subject to respond either by pressing a button or raise their hand. Advantages of pure tone audiometry screening. Pure tone audiometry screening is the most common hearing screening test for children and adults, as most community screening programs will involve pure tone audiometry. It is also a quick and easy method. It can take as quickly as 30 to 60 seconds for a full screening using this Welch-Allyn Audioscope 3 screening audiometer. It is a handheld otoscope with a built-in audiometer that delivers a tone at 25 or 40 dB for 500, 1000, 2000, and 4000 Hz. The subject will indicate the tone was heard by raising a finger. PTA screening gives reliable results, as it complements other screening tests like tympanometry and otoscopic examinations for consistency. The whole auditory pathway into the brain is measured in pure tone audiometry screening, unlike other tests such as the auditory brainstem response, which only measures up to lateral lemniscus. Next, Audiometers can be ultra-portable, like this ESCAN3 screening audiometer, which weighs less than 10 ounces. Some audiometers also allow the subjects to do the assessment on their own. For example, the GSI arm task allows self-screening as it has built-in quality indicators to make sure the test is reliable even with minimal supervision.
Good morning, Sir Almeida and my friends. I'm Chang Xin Jing, and now it's my turn to present to you the disadvantages, or in other words, limitation of pure tone audiometry screening. The main limitation of PTS screening is low sensitivity and specificity. A good screening test should achieve high rate of true positive and high rate of true negative. However, an investigation showed that PTS screening only achieved 50% sensitivity and 78% of specificity. This statistic is far away from the ideal screening test, which should achieve 100% sensitivity and specificity. The other limitation of PTS screening is there are many factors that can affect the results. The first one is ambient noise. In other words, background noise. If the background noise is too loud, PTS screening cannot be done because it will affect its accuracy. The second factor is environmental distraction. Since PTS is a subjective test that requires cooperation from patients, their state of attention is very crucial during the screening. The third factor, tester competence. The experience and techniques of the tester will greatly affect the screening result. And finally, patient developmental stage and behavior. Patients need to be cognitively and physically mature enough in order to understand the instruction and give cooperation to the tester. Despite of the poor performance of PTS screening, we have no better options to identify hearing loss in terms of degree and type. Because autoacoustic emission screening cannot test for the auditory nerve part, and tympanometry measures only the status of middle ear. Therefore, PTS is still the most common test used for hearing screening, but we need to consider its limitation by adopting practices to enhance its validity, such as we can conduct regular training sessions for tester, or providing a quiet room, or to carry out a rescreen. There are a few of considerations we need to take note during PTS screening, such as the screening need to be done in a very quiet room, and environment noise level check should be done before we do the screening, re-instruct the children if they cannot understand the instruction, or refer them to play audiometry if it is really difficult to screen them. These considerations, which will be discussed in the few following slides, also can be known as protocols. Protocol can be defined as formal documents that typically outline the requirements, activities, resources, documentation, and schedules to be completed. In this case, I would like to use the school setting to explain PTS screening protocol. The screening protocols for other settings are more or less the same. Right, now we come to the first screening protocol, screening schedule. Most PTS screening is carried out among the young students because it is estimated up to 15% students will have at least a transient hearing loss during their school years. We always focus on this group of people because early in the identification of hearing loss is important to enable the early intervention on speech and language development. Next, we come to the use of volunteers. It is not necessarily that audiologist is the only one who can perform the screening test, but volunteers are also useful during initial sleep screening. But they need to be trained before they perform the screening test. Volunteers should be familiar and feel comfortable with equipment, screening forms, and procedure to increase the screening accuracy. They also should be counseled regarding the confidentiality. Now we come to the care of equipment. The equipments that used in PTS screening are basically audiometer and headphones. These equipments need to be stored in an area that is climate controlled and calibrated annually to ensure the accuracy of the results. Headphones should not be transferred from one audiometer to another without calibration, and they should be cleaned from time to time. Pre-screening education is also one of the screening protocol. Nurse can orient the kindergarten children to the equipments and procedures because this will give them a better idea of what is expected of them. How can they do this? Maybe they can take the audiometer to the classroom and demonstrate to the children how the headphones are placed and how the tone sounds like. Then let them to be familiar with the sounds, with the tone, and then need to instruct them to raise their hand when they hear the sound and put their hand down when they cannot hear the sound. The fifth protocol, preparing the child for screening. Simple instructions need to be given to the child face to face, and testers should stress the importance of responding quickly to the tone, even if the tone is very faint. We can prepare the child in 3 ways. The first one is by standard instruction, which is the conventional way of giving them an instruction. The second way is modified instruction, which can be given to the younger children or individuals with cognitive delay. We can insert play technique to the child by asking them to drop the blocks or simple toys when they hear a sound. The third way of preparing the child for screening is by demonstration of procedure. Instead of giving them instruction, tester can demonstrate how to perform the screening to the children. Now we come to a very important screening protocol, screening environment. The choice of hearing screening environment is very important. The environment needs to be quiet, and sound-treated areas such as library or music room shall be made use of. It is better if the environment has limited visual distraction. The room shall accommodate a table, chairs, and electric outlet. Ideally, there is only one screener per room. Number 7, ambient noise level check. The ambient noise level should not exceed the level shown in this sound meter chart. If the ambient noise level is really too high, the screening procedures should not be implemented. So before we start to do a screening, we should check the ambient noise level by using an audiometer. Here is the way to check the ambient noise level. If the noise level is too high, it will effectively mask the threshold and give us an inaccurate pure tone threshold. So in order to solve this problem, we can use some alternative methods such as cover the floor with carpet or apply some absorptive acoustically treatment to walls and ceilings. And I would like to stress again, if the noise level is really too high during screening, the test should be stopped. This is the flow chart of PTS screening. Individuals who pass the first stage of PTS screening can be discharged, and for those who fail, they need to be rescreened in 14 to 21 days. And in this stage, those who pass can be discharged, and those who fail need to be referred for further evaluation. Rescreen. Rescreen is important to get the accurate screening result. We need to rescreen the group of patients who failed the test. In clinical setting, patients can come back to do the rescreen after 8 to 10 weeks, whereas for community setting, PTS rescreening should be done in 14 to 21 days. That's all from our presentation on the topic of hearing screening and update of pure tone audiometry tests. Thank you for listening.